welcome to the MedEClasses PG lecture series in which we will be talking about a very important and interesting topic of DSD. And this is something which is extremely common, extremely important, and has got huge implications in terms of evaluation and management. So, Dr. Vibha, why do you think DSD is one of the most enigmatic part that we deal in pediatric endocrinology? What are the challenges that are there in terms of evaluation?
So first of all, the identification whether there is a DSD or not, because some of the DSD mimics may cause confusion, and one of the most important consideration is the excess DSD, which is 21 hydroxyl and which is a life-threatening condition. So identification of excess DSD in an early stage is very important to prevent the grave consequences. So in these scenarios, this is important to identify the DSD at the right time.
And what are the common forms of DSD that you encounter in our clinical practice?
The most common that we encountered in OPD is 21 hydroxylase, and the in pubertal age group aromatase deficiency, and rare form of 11 hydroxylase, rarely we do get.
And of course, XYDSD is one of the ones which are
XYDSD, yes,
very
sir, definitely
challenging.
in the boys, XYDSD, 17 beta HSD, and 5 alpha reductase we do
So
have.
XY is something which is often very challenging to diagnose and much more difficult. XS seems to be important because of clinical relevance. So both spectrum becomes important. So what we'll do is that over the next hour or so, we're going to discuss about the pathophysiology, the etiology, evaluation and management of DSD. And at the end, we will have objective structured questions which will be done by Dr. Nimisha. So we'll start off about DSD. And DSD is something which is extremely important to identify, as discussed by Dr. Vibha, because there are lots of implications. So we'll talk about two cases where the diagnosis made a big difference. So we had a 1-month-old boy, child with DSD, who was referred to us with Prader stage 4. And what really happened was there were classical features of XY-DSD. Now, this individual had been given testosterone, 3 doses, and people thought that this is XYDSD. We have done our picture and then we'll go for surgery. But unfortunately, despite the various increase and everything happened, 5 years later developed renal failure. So what's very important to understand is that our job is not just done by identifying a DSD or giving some cosmetic measure. We also have to think of a serious underlying disorder, which could be something like a WT1 defect, which can result in renal failure. So a comprehensive evaluation of DSD therefore is extremely important. The second scenario was more of a diagnostic challenge, a day 3 child with DSD who again presented with Prader 4 with no gonad. So this looks like XX-DSD, and on further evaluation was found to have the Mullerian structures, and the karyotype was 46XX, again confirming. At that point of time, a borderline 17-OHP was identified, and based on that, a diagnosis of 21 hydroxylase deficiency was made, and the child was labeled for life in terms of treatment. Now, what happened by the treating physician was that they found that they could actually cut down on the dose of hydrocortisone, and the 17-OHP remained normal, which really excluded CAH as a possibility. If you look in retrospect, the amount of 17-OHP elevation was not remarkable, and this brought us to some alternate diagnosis. And when we evaluated, we found that there was delayed puberty. Now the child presented around 14 years of age with delayed puberty. On retrospect, there was a history of maternal virilization, giving a clue to aromatase deficiency. The key message is that if you identify XYDSD, don't just get satisfied with the diagnosis and treatment, think of an underlying cause. And not all XXDSDs are CAH. This is something which is extremely important to understand from that regards. All of you can go and have a look at our website learning.society.in, which has got multiple source courses and resources, including fellowship in pediatric endocrinology, our e-learning platform, the YouTube channel, which has got large number of information available. We have got courses which are available, and including fellowship and postgraduate programs which are there, which can be accessed online as well as on a hybrid mode. We run regular programs in the form of grand rounds, journal clubs, and PG lecture series. This lecture series is part of a 36 lecture series which aims to cover the entirety of pediatric endocrinology over a 3-year period. We have already conducted around 15 such lectures. They are all available on YouTube. You can go and have a look at that in detail in terms of that. There are multiple publications which provide coverage in terms of pediatric endocrinology, right from protocols to basic and to advanced pediatric endocrinology. Our latest application is now available on both Android and iOS store. It looks into entirety of pediatric endocrinology. So we'll talk about PG lecture series. I'll be joined by our consultant in pediatric endocrinology at Regency TDR, Dr. Vibha, who will be talking about etiology, and Dr. Nimishar, fellow, will be talking about some very interesting cases. So when we talk about sexual development, we know that the development starts from a single cell stage, which is quite similar for both genders. And from there, we have the development of the genetic sex, the development of the internal gonads, the hormone action, and the identity to develop into the boy and girl. And this is a complicated process, and it's not really unexpected that we can have errors at any point of time from that regards. So we'll talk a bit about pathophysiology because this is important for understanding. When we talk about gonads are developed using two different structures. So like many other endocrine organs like thyroid, like pancreas, like adrenal, they are developed by two different types of cells. So we have got the urogenital ridge, which starts around 4 to 6 weeks, from which there is a bipotential gonad, which is developed. And this requires a number of primitive or early transcription factors, including CABX2 and GATA4. Very important transcription factor from a pathophysiological perspective include NR5A1, which is also involved in adrenal development, and WT1, which is also involved in the renal development. And as we discussed in the first case, whenever you're looking at gonadal developmental issues, think of kidneys, think of adrenals as well. Now, these NR5A1 and WT1 play a crucial role in terms of the development of the bipotential gonad, which at this stage is basically can develop both into testes and ovaries. And we're talking about just the structural sense. The germ cells, the second component, is going to come from the hind gut, and from there it is going to migrate. So I will focus mainly in terms of the hormonal function, so to speak, from that perspective. Now, the major determinant of the switch of gender, so to speak, is SRY. But now we know there are many more genes involved, and SRY working with NR5A1 activates a very, very important protestis gene, which is the SOX9, which results in the development of the testis. There are also anti-testis gene or pro-ovaries gene in the form of FOXL2 and DAX1, which will promote the development of ovaries. So while we consider, often people consider that the ovarian and the female development is more like a default mode, there are actually proactive genes and transcription factors which are working in the development in that regards. And these would then have a combination of a pathway, including the WNG and the catenin, which is a canonical pathway, which will result in ovarian development. There is a clash between the protestis, which is SOX9, and pro-ovary gene FOXL2. So disorders of sexual development can happen, can have many abnormalities in any of the genes. Now, if you look at it from this perspective, if there is no WT1, there is no NR5A1, there will be no gonad which will develop. If there's a problem in SOX9 or FOXL2, the testis will not develop. While if you have an overexpression of DAX1 or FOXL2, you will have an abnormality in which testis will regress, resulting in a XYDSD. So this framework is important to understand from that regard. Now, when we talk about testicular development, we know that there are two cells or two compartments of testis from that perspective. The SRY gene plays a major role in the testicular development. There is the germ cell and the myoid cell component where it is working. NR5A1 is not only involved in the development of the bipotential gonad, it also has a direct effect on the Leydig cell, which then produces the insulin-like factor 3, causing testicular descent till the inguinal region. Now, testosterone produced again via the Leydig cell compartment plays an important role in further testicular growth. SOX9 plays a very vital role in terms of Sertoli cell development, which is a source of inhibin B, and AMH, which is again involved in testicular descent. So, for the testis to descend in the scrotum, it has to itself produce multiple protectors like insulin-like factor 3, AMH, and testosterone. So if a testis is scrotal, this itself means that the testis is well developed. It has got both Sertoli and Leydig cell components, and therefore there will be a significant amount of testicular function which is preserved. On the other hand, if you have a problem of both the compartment, the testis will actually be abdominal. While if there is a predominant effect in terms of androgen production or action, the testis will be inguinal. So location of testis will give you a good idea as to wherein is the defect in terms of testicular development or maturation in that regards. The ovarian development, although it is considered to be a passive phenomena, involves multiple genes which are there to develop. So we already discussed some of them like WNT4 and RSPO1, along with the beta-catenin canonical pathway with multiple genes like FOXL2, DAX1 and bone morphogenic protein 2, which result in the development of the theca cell, which produces androstenedione and inhibin B. Now, theca cell you can consider to be as similar as the Leydig cell in the testis. We have got the oocyte, the figula, no box, which produce that, and the granulosa cell, which produces estrogen and AMH. So both these factors play an important role in terms of ovarian development. So if you have an individual who is XY, in whom SRY is not there, that would mean that there will be no testicular development. Ovaries may develop, but because the lack of many of these gene expressions, you may not have a fully functional ovary. Similarly, if you have an XX individual in which SRY is inserted, that may be enough to cause a male development, but then that testis is not going to develop further, and this will result in infertility subsequently from that perspective. Now, how is the testicular development regulated? We are all aware about the hypothalamic pituitary testicular axis. So, GnRH from the hypothalamus activates the FSH and LH, and they work separately on different compartments of the testis. So LH acts on the LHCG receptor in the Leydig cell to produce testosterone along with insulin-like factor 3, while FSH acts in the Sertoli cells to produce AMH, which is an important factor in that regards. Now, this testosterone is to be converted into 5-alpha reductase 2 to dihydrotestosterone, which is the potent form of testosterone. Very importantly, the HCG produced by the placenta will take care of testosterone production during the crucial 8 to 12 weeks of gestation. That is the most important phase, because there not only you have got the penile growth which is happening, but also the labioscrotal fusion. So individuals who have hypogonadotropic hypogonadism, wherein LH is not there, the HCG will take care of them, and they will present to us with isolated micropenis and not hypospadia. The presence of atypical genitalia suggests that there is testosterone deficiency or problem in testosterone action at around 8 to 12 weeks, and that's something which will give us a clue in terms of diagnosis. Now, this 5-alpha reductase will of course have to work, the dihydrotestosterone has to work on the androgen receptor to produce the secondary problems. Secondary development in the form of penile growth, in the form of penoscrotal fusion. So, abnormalities in the testosterone production, activation to dihydrotestosterone, or action of dihydrotestosterone may therefore result in XYDSD. Ovaries are often considered to be a default mode. Again, we have got the LH, which is acting on the theca cell to produce androstenedione, which is then converted via the FSH using aromatase to estradiol. Isolated LH deficiency or LH resistance will not going to cause any problem in terms of development of a girl. They will have predominant effect in terms of ovulation. Similarly, problems in FSH also are not going to cause DSD. They are going to cause delayed puberty, primary amenorrhea as a primary scenario. However, if there is a problem in aromatase, which is converting the androgens to estrogen, there would be too much androgens which are there in the body, and this will result in a X6-DSD. So in general terms, when we talk about the overall classification of XY-DSD versus XX-DSD, the basic difference is that XY-DSD is an act of omission, while XX-DSD is an act of commission. So if you do not have a bipotential gonad, If you do not have a testis, do not have a testosterone, do not have a 5 alpha reductase, do not have androgen receptor, you will have a XYDSD. But if you have nothing, no ovary, no LH, no FSH, no estrogen receptor, still the development will be a normal female at birth. There will be no DSD. They will present later on with primary amenorrhea and delayed puberty. If you want to have XXDSD or atypical genitalia right at birth, there has to be some source of androgen production, which basically can come via the adrenals or the ovaries in that perspective. And this is something important to understand. Now, because testosterone production is common both to testis and adrenal, and there are many enzymes which are common to that, we need to understand a bit of that. So the 7-dehydroxycholesterol is converted via the DHC reductase into cholesterol, and this is a very important step in terms of cholesterol synthesis, and this will result in an impact of every aspect of steroidogenesis. This cholesterol is then converted via three major enzymes, the proximal enzymes as we say, side chain cleavage, star and 3-beta HSD into progesterone, which is then converted in the testis via 17-hydroxylase to androstenedione, 17-beta hydroxylase to dehydrogenase to testosterone, which is then activated via 5-alpha reductase to dihydrotestosterone, which has 100 times greater affinity to the androgen receptor, and this DHT will then act on androgen receptor to cause the overall action. The enzymes DHC, side chain cleavage, star, 3-beta HSD, 17-hydroxylase are common to the testis and the adrenals. So problem in these, if we talk about 3-beta, side chain cleavage, star and DHC will result in combined adrenotesticular defect resulting in salt wasting and XYDSD, while 17-hydroxylase deficiency will result in accumulation of lot of DOC, will cause hypertension and XYDSD. So looking at salt status will give you direct clue as to which way you are going in terms of overall development from that regards. Now this testosterone is of course aromatized into estradiol, and as we discussed, aromatase deficiency will have different manifestations in boys and girls. What about ovarian? Again, the same enzyme, the side chain cleavage, star 3-beta HSD are common. From progesterone, we have got the 17 and 21 hydroxylase and finally aromatase. Out of these, the one which can present to us with a problem in terms of XXDSD would of course be disorders in which adrenals are producing more amount of androgens. The classical example of that would be 21 hydroxylase and 3-beta HSD, and aromatase deficiency in which whatever androgen is being produced is not getting converted into estrogen. So these are the disorders you need to be aware about from that regards. Now, the androgen action involves the activation of testosterone to dihydrotestosterone, and you can consider testosterone to be a pro-hormone. It has to be activated to DHT, which has got much more potency compared to testosterone, which goes into the nucleus, activates the process resulting in androgen action. Now, in conditions where there is a problem of conversion of testosterone to dihydrotestosterone, there will be no effect during the time when testosterone levels are low. But if the testosterone levels go really high, that is during the mini puberty in the first 1 year of life, and then in puberty, this testosterone will start acting in that regards. Secondly, the internal structures are bathed with very high level of testosterone. So individuals with 5-alpha reductase deficiency will have major effect in terms of external genitalia. The internal genitalia, the seminal vesicle, the prostate and all the other factors will develop. The other thing would be that when puberty happens, the testosterone levels will skyrocket and there will be development of these genitalia which will happen. So a classical presentation of 5-alpha reductase deficiency is in terms of an individual who looks like, who's reared as a female, and suddenly in puberty the penile size, the clitoral size increases, there is virilization, and typically we say is like a scenario of penis at 9 in that regards. Now, how does this all development happens? We have discussed about the gonads. What about the internal genitalia? So again, there is a commonality in both the genders at 7 weeks. So when the testis is being made by 5 weeks, 7 weeks AMH comes, it is going to abolish the Mullerian duct. Mullerian duct abolition is essential for subsequent internal structure development. So this precedes the testosterone action. If there is no Mullerian structure in an individual, that means that the testes were there sometime. They may be abdominal or they are currently present. So absence of Mullerian structure is indicative of an underlying testis which produced AMH. By 8 weeks, testosterone comes into the picture, which acts on the Wolffian duct to produce epididymis, vas deferens, and seminal vesicle. Females, you will have a different development clearly from that perspective. You will have persistence of Mullerian structure. There is no testosterone, so Wolffian structures will go up. Estrogen will sustain along with WNT4, and Mullerian duct will develop into fallopian tube, uterus, and upper vagina, giving us a female reproductive structure. External genitalia development is also equally responsive to androgens, and very important thing to remember is that the 8 to 12 weeks is crucial in terms of labioscrotal fusion. So if you have androgen excess in an XX individual beyond 12 weeks, you will have clitoromegaly, you will not have labioscrotal fusion. Similarly, if there is androgen deficiency in an XY individual, there would be micropenis and not hypospadia from that regard. So of course, no fusion happens after 12 weeks of gestation in that perspective. Now we know that placenta plays a very, very important role in protecting the female fetus from the excess amount of androgens and the male fetus from excess of estrogen. So androgen and estrogen are both cleaved at the level of placenta using 7-beta HSD3. So excessive androgens are not going to cause a problem. But if the androgen levels are very, very high in the setting of a maternal tumor, you may see some virilization which may happen. Or if drugs like diethyl stilbestrol are used, which do not get inactivated by 17-beta HSD, that may cause feminization of the fetus. Now, fetus is largely, the fetal adrenal is the factory of DHEAS. It produces all that, and this has to be converted via aromatase to estriol. So in conditions where there is aromatase deficiency, you will have excessive amount of androgens both in mother causing maternal virilization and the child causing DSD, as we saw in the second case in that regards. Very importantly, gender identity is a very complicated process. It is determined by number of factors, but a very important factor is the antenatal testosterone exposure. So in conditions where the antenatal androgens are very high, there is a high likelihood of male gender identity, and this is very, very important from the setting of 5-alpha reductase. Similarly, severely virilized 21-hydroxylase individuals may have issues of male gender identity, which we have to consider subsequently. So to summarize, in terms of sexual development, we have got genetics, followed by the gonadal development. And when we talk about gonadal development, there's adrenal and kidney development. They then produce the hormones testosterone and estradiol, which act on their receptor to cause the differentiation in that regards. Now, XYDHD, as I said, are acts of omission, wherein you have problems in terms of testicular development. Along with that, you may have adrenal or renal dysgenesis in that regards. Now, AMH is going to cause the regression of Mullerian structure. If AMH is also lost, you will have persistent Mullerian structure. So, uterus will be present. However, if there is a problem in the testosterone production, what we need to understand is that adrenal problems can be common. So CH becomes important. Along with that, AMH will be produced, so there will be no uterus. So testosterone problem, activation problem, androgen receptor problem, there will be no Mullerian structure in that regards. XXDSD are largely acts of commission, so you can have increased production of androgens from the ovaries or from the adrenal.